set it. There we go. Okay, well, folks are rolling in here. I just want to say welcome. Thank you for attending the, oh, I keep hitting that button. Thank you for joining us for this really, open discussion on aneurysms outside the aortic root. As part of Loeys-Dietz Awareness Month. This is something that we know primarily within our communities, primarily affects Loeys-Dietz folks, but, could be something that if you have another condition connected like this may be a topic that is also of interest to you. So you're also welcome, of course. We are really fortunate to have both Gretchen MacCarrick, the one, the only, and the Dr. Black with us as well for this conversation. We will be taking questions. So if you have them as we're going, please feel free to drop them into the Q&A portion of your Zoom screen there. I'll try to keep up with the chat if folks are in there too, but sometimes it's easier to find questions right in the Q&A. With that, I also just want to mention as we're going here, this is June is Loeys-Dietz Awareness Month. And so we've spent a good portion of this month really trying to push out lots of FAQs and resources and ways to engage with community and help support this work. But also the most important thing is that people with Loeys-Dietz get the information that they need to live successfully or live the lives that they would like to live. Whether you're a caregiver, you're a person who lives with Loeys-Dietz, or somewhere, both, sometimes you can be both or whatever. We want to make sure you have all the information you want and need in order to support that life. So a few things of note here, just Loeys-Dietz.org is where everything we have lives. The main bulk of the resources as far as downloads, things about, toolkits and things like that are all at Loeys-Dietz.org/resources. The other site, the other page I want to point out is Loeys-Dietz.org/ask. This leads to a form where you can submit your question and your information, and our on-staff nurse will get back with you usually within 24 hours to answer your question or follow up with you to get more information. When she does not have the answer right offhand, she reaches out to folks just like Gretchen and Dr. Black and others who serve on our professional advisory board. We're here to make sure that you have the information you need. So please, please, please ask those questions. Any kind of question, please. We will do everything we can to make sure that you have the information you need to make what are oftentimes difficult decisions about your life or healthcare, et cetera. And then another spot I want to just make sure everyone is aware of is our YouTube channel, which is a part of the Marfan Foundation. This is a wonderful video library of all kinds of topics related to Loeys-Dietz, Marfan, general connective tissue condition questions, there are some mental health topics, just a whole range of things that might be of interest there. So if you ever have a question and you just want to see what the folks from our professional advisory board might suggest on that, our YouTube site is another good place to check. So with that, we will do our best to answer all the questions we can during this presentation. But if we don't get to it, or if it's a little bit more specific to your situation, these are all good places to look for answers to the questions that you should always be seeking to answer. So with that, again, I just want to welcome you. I'm Angela Christ. I'm the director of the Loeys-Dietz Syndrome Foundation, and joining us for this conversation are Dr. James Black, who's the chief of the Division of Vascular Surgery and Endovascular Therapy at Johns Hopkins University, and Gretchen MacCarrick, the one and the only, I always say, genetic counselor at Johns Hopkins University. And with that, I will hand it over to Gretchen, who's going to run our presentation for the rest of this discussion.
Well, maybe as I'm getting my slides at Dr. Black, people are sick to death and know me, but like how did you get kind of roped into vascular connective tissue disorders and kind of what has this population kind of meant to you as we get started, maybe kind of what's your story of getting involved with VEDS and Loeys-Dietz and Marfan?
Yeah, so, you know, a long time ago, so this would have been when I was just coming back to Johns Hopkins. I had been here since 95 to 2002, trained at the Massachusetts General Hospital, and came back with an interest in doing aortic surgery. I'd seen a great number of aortic surgery cases, both here at Hopkins and then also at Massachusetts General Hospital with a surgeon named Dr. Cambria. So it seemed like a natural step to come back to Hopkins. And indeed, I also wanted to be involved in the science of aortic diseases. And so naturally it came to work with Hal Dietz. And there's a long story, but I'll sum it up to say that in 2007, when the TGF-beta story started to really become more clear, and I was working in the lab, every time I went to the lab to work on my science, Hal would come back from clinic with another 2 or 3 patients who I needed to operate on right away. It was early in the course of both my scientific career, but it was also early in the course of our understanding of Loeys-Dietz syndrome. And so, of course, way back then, we didn't have the understanding we have now of Loeys-Dietz. And so I was doing a lot of operations, and that was sort of the end of my science career. So I get to blame that on Hal. But it's been really one of the best parts of my career to take care of patients with genetically based vascular conditions. And of course, I've then studied and published some of the early papers on vascular Ehlers-Danlos syndrome, particularly showing that for people with vascular ES, that waiting until rupture or some life crisis, you know, may be the wrong approach. So we've leaned in really on all connective tissue disorders here at Hopkins, but we've also leaned in clinically, not just scientifically. So we have a great team here, and like I said, it's been one of the great parts of my career to date.
Thanks. I'm really excited that we have the opportunity to kind of sit down and talk about these things. And I feel like when patients or like when we give these webinars, people are coming in with like either vast amount of knowledge or like no knowledge. So we're going to try to like meet the needs of everyone. And so we do have some like literature and science or studies, but then also like really just basic vocabulary. So hopefully, you know, feel free to chat and ask questions. But our agenda for this evening is kind of just go through vocabulary and anatomy to get people kind of on the same level. And then kind of to walk through the vasculature and kind of what we know about Loeys-Dietz syndrome and surgeries, starting with the arch, and then Dr. Black's favorite area, the descending aorta, looking at abdominal arteries. We've tried to get some of our neurovascular colleagues, and we can never get the date to work out. So I promise someday we'll get our neurovascular team connected to a webinar. But then also I've had the opportunity to like take some time and go through the literature, because I know people have a lot of questions about like, what about my type and what do you know about that? So we'll be able to present some updated numbers and percentages there. And again, if any questions, just chat. Hopefully this is really kind of calm and chill. And I give Dr. Black full permission to just interrupt us at any time. So you all know, or maybe you don't know, but when thinking about the vascular anatomy, we all kind of think about the aorta, right? The big candy cane tube that brings blood from the heart to the rest of the body. And kind of the canary in the coal mine, the place that goes bad first is that aortic root. And so today we're really going to talk about the rest of the aorta, kind of curves over into the arch and the descending down into the abdomen. And then we have all these branch vessels that come off that candy cane, right? They go off to the arms and the legs and the neck vessels and the spine and all the organs in the belly. So when we're thinking about arterial aneurysms, we're kind of thinking of those off branches.
Hey, Gretchen.
Yeah.
I'm really sorry to interrupt you. Could you switch to the other view?
Oh, I'm sorry.
There we go.
Okay. It was my screens. My 2 screens got confused. I apologize. And I will say one cool thing too, just about our anatomy in general, especially in our head, is that we have kind of carotids and vertebrals that come up our neck. But then they kind of in the brain, they create this circle. And so some people have questions about if something happens to one side, or if you have to have surgery and occlude something on one side. Our anatomy in our head is pretty cool, that circle kind of allows blood to get everywhere it needs to, especially if just one side is occluded. Okay. So a lot of people with Loeys-Dietz syndrome, I think studies range from like 80 to almost like 95% have something called vascular tortuosity. Often it's in your carotids or your vertebrals, your neck vessels, sometimes in your abdomen vessels. And really it describes like curlicue, kinking, winding. Sometimes there's even like corkscrew turns, and they don't necessarily represent bad blood vessels that you're going to get aneurysms in those locations, but they're just kind of diagnostic clues. But sometimes they can make interpretation of imaging in your head and neck a little bit tricky because they might look a little wide when they're just kind of winding around.
And also, I think it's important to mention on the subject of the carotids that the tortuosity of a carotid vessel has actually been studied really extensively going back decades. And so tortuosity of the carotid vessels is actually not associated with stroke. Tortuosity of the carotid vessels can be associated with other vascular manifestations of Loeys-Dietz syndrome, might be a surrogate for some of the more severe forms of Loeys-Dietz, but it's definitely not a stroke problem. So people should feel better about that, hopefully.
Great. So when we think about aneurysms, especially in other portions, not the aortic root, there can be kind of different ways to describe aneurysms. So again, as a reminder, kind of aortic tissue is kind of 3 layers. And so we can see what is I guess maybe typical in the descending or other places is kind of this fusiform or tubular aorta, which is kind of an enlargement of the entire vessel. But you can also see what's called this saccular aneurysm. So this is kind of an outpouching of all 3 layers, kind of like a bubble outpouching. And then in Loeys-Dietz syndrome, especially compared to maybe some of like Marfan syndrome, we do actually see what's called pseudoaneurysm. So this is kind of like a blistering out of just like the outermost layer and kind of an outpouching of not all 3 layers, but 1 layer. And I'll be honest with you, we see this more and more in Loeys-Dietz syndrome after people have had surgery. So if you've had a graft replacement, oftentimes we can see this pseudoaneurysm or bubble either like at the root or in the distal graft. And we don't see it as often, at least maybe Dr. Black can tell us about the descending, but in the ascending, we don't see it as frequently in other disorders compared to Loeys-Dietz syndrome. Often it's asymptomatic and you just see it on imaging, but sometimes if the pseudoaneurysms become so large, it can impinge upon parts of your lung or your esophagus, which can be a hint that something is going on. And in rare cases, if there's an outpouching, it can actually kind of fuse with lung tissue and it can create a fistula into your lung. So we've actually seen some patients who've presented with bleeding lungs or vomiting blood, and they actually have this fistula. Sometimes we think it comes from like a suture stitch that has popped and it has that little blister outpouching there. But I don't know if it has to do with inflammation in Loeys-Dietz syndrome in the tissue, but it's interesting that we don't see it that often in other conditions. But I don't know if you see this more frequently in other arteries, Dr. Black, or mainly we see it in the root and the graft.
Yeah, I mean, pseudoaneurysms, interestingly, at least for patients with vascular Ehlers-Danlos syndrome, it's actually their most common type of aneurysm, is a pseudoaneurysm, usually in association with an asymptomatic dissection, usually in the iliac arteries, less commonly actually in the aorta. Pseudoaneurysms in general, particularly in association with grafts, usually implies some degeneration around the time. And this is a real area of research and technical refinement for the cardiac surgery teams to sort of find ways to make these grafts more secure to tissues that might have an underlying level of weakness to them.
And then when we go on to think about dissections, I think there's usually kind of 2 different ways to think about them. Usually a type A is a dissection or tear that starts in the root or kind of in the ascending aorta in the chest. And it can either be isolated there or it can unzipper all the way down. And this is compared to like a type B dissection where kind of the root and the arch are spared, that dissection happens kind of in the going down portion in your chest in the descending aorta. And I will say that, compared to aneurysms in the root, they're really big clues to us that someone could be at risk of a dissection. There's still a lot to learn about type B dissections in the descending, because oftentimes people don't have a whopping big aneurysm there to predict that a type B or descending dissection is going to happen. And a lot of the literature or reports that you'll see about dissection risk after pregnancy, a lot of that can be attributed to type B. And so when it comes to like description of blood flow and dissections, this is one I'm going to pass to Dr. Black because I want to hear his description of like, how would you describe like true lumen versus false lumen and what you're managing in a type B dissection?
All right, so, as Gretchen did mention, type B dissections are somewhat more common in different populations. If you just type in aortic dissection, almost always the literature is going to lead you down the path of a type A dissection. And a type A dissection, as sort of depicted on the pictorial on screen left there, starts near the aortic root. And because the aortic root is so mobile and there's so much hemodynamic stress down at the root, those type A dissections have a mortality risk, which is really significant, and therefore they are a surgical emergency. The type B dissections, though, are different. Yes, there's hemodynamic stress on the aorta in this location, but as Gretchen said, most of these don't occur in the setting of a pre-existing aneurysm. So there probably is some biology there that's active, and it's not just Loeys-Dietz. It could be Marfan's, it could be other familial thoracic syndromes that we see. But yes, once that tear opens up and you get blood surging down through those layers, you get what's called the true lumen, which is where the blood should be, and the false lumen, which is usually where the blood is escaping into through the aortic tear. So on the pictures you see here, you sort of see this sort of a notation of a false channel. The false channel is just the channel where the blood is going as part of the dissection. And there are strategies we do to manage that. The first, of course, is blood pressure control. To take the blood pressure down, reduce the amount of cycles of stress and blood pressure surging into that false lumen. That's always the first step. And then in some patients, there's some forms of surgery, stents or open surgical procedures we would pursue next.
And so really the imaging that we use to look for aneurysms and look for tortuosity and dissections is MRAs or CTAs. So you're really not going to see these things just on your routine echo. And that's why head to pelvis vascular imaging is important for Loeys-Dietz syndrome patients. You're probably aware of kind of like the pros and cons of MRA versus CTA. The A kind of implies contrast or angiogram, so it allows us to really look at the blood vessels. With an MRA, it does take a longer time frame to get the image, but there's no radiation. With a CTA, they are like getting faster and less radiation, but there is radiation associated with it. It can be a little bit better for clearer blood or a little bit clearer for smaller blood vessels like in the head or the neck. And in usually like an emergency situation, if you're presenting to an ED with pain, CTA is kind of going to be your standard, what they're going to do in an emergency.
Yeah, CTA is just very widely available, and MRI sometimes just isn't available in some hospitals on some hours.
Yeah. And so when we think about other surgeries outside of the thoracic aorta, the root or the ascending, we start thinking about different surgical interventions, say in the aortic arch. So again, that kind of curve part. And there can be repairs called this hemiarch, which is your first slide on the left, where they kind of go up to the branch vessels and then kind of replace the underneath of the aorta in anticipation of maybe needing a larger surgery in the future. There can be a total arch replacement where you're actually replacing the arch, but then you have to kind of undo those blood vessels that are coming off into the neck area. So you have a little bit of graft going up there. And then Dr. Black, maybe you want to describe an elephant trunk and kind of what that repair is.
Sure. So elephant trunk surgery was a surgery technique that came around in sort of the mid 1990s, actually in Germany, but it really went worldwide very quickly. And what it is really this sort of screen right picture here, where you see a surgical connection made into the aortic arch. So right where sort of you see the two vessels sort of tied off with sutures, there's a graft that actually dangles down like an elephant trunk inside the channel of the aorta. And so later on, that piece of graft that's inside the aorta can be used. And it doesn't have to be used right away. It can be used months and years later to then fix the descending thoracic aorta as it runs down through the left chest into this, along the spine to the abdomen. It can be used to help fix that piece of aorta down the road. So it's a technique we use a lot, particularly if the descending thoracic aorta is a little bit dilated at the time of the arch repair.
So there was an interesting paper that came out. Dr. Black, I don't know if you're on it. So I know that some people from
Yeah.
Hopkins and Florian is on it. Maybe you are.
I'm on it, yeah.
Oh, great. So I'll give you my interpretation after talking to Dr. Dietz, and you can add anything. So this paper came out in 2020, and it was looking at arch repairs in a cohort of Loeys-Dietz patients and Marfan patients. So the Loeys-Dietz is in blue, the Marfan is in red to orient yourself. So some key things, just the Marfan population that was studied. And I think this came from probably a surgical cohort. So people who had made it to some type of aortic surgery. So the Marfan, is about, 3 or 4 times as much. But if you can look at the mean age of presentation or of study too, it's a little bit later age in the Marfan population. And so if you look down at kind of the next level, we see that about kind of almost equal, maybe-ish, patients with Marfan and Loeys-Dietz presented with aortic dissection. But one big difference, if you look at the cohorts, is that in Loeys-Dietz syndrome, there was 6 type A and 7 type B, so kind of equal where it originated. And then Marfan syndrome, by far type A dissections were most common. And then the other percentages just had aortic root surgery. And so if you go on to see how many needed arch surgery with or without dissection, with or after dissection, I guess, about 60% had arch surgery with their initial dissection. But again, this might be a little underestimated because it was pretty much everyone who had a type A dissection, whereas half of this group had type B dissections, and often you don't go backwards. So this is a little bit, the lowness of it is a little bit reflective of the kind of the more type B dissections that happen in Loeys-Dietz. Whereas compared to Marfan syndrome, about 90% who presented with a dissection went on to have arch surgery. But the big difference here is that people who just had their aortic root repaired, so no dissection, 16% of Loeys-Dietz patients did end up needing an arch surgery as like a completely independent surgery, whereas only compared to 2% of Marfan patients ended up having arch dilation that needed later surgery. So that's a big difference of just like independent aneurysm development, not associated with dissection. And kind of an explanation, I was a little taken aback with like how many, the difference between who had arch surgeries with the initial dissection, because it seems much higher in Marfan syndrome. But again, this probably reflects a much higher incidence of type A dissections. And it also reflects likely a younger population, including children, having dissections. And so, with you want to repair the dissection, and in a younger kid, you might not want to have them under as long. And so this is a reflection of both more type Bs, but also a younger population. I don't know if you have anything to add about that, but.
Yeah, I think it's an important distinction to draw. One, that the aortic root, although one of the cardinal features of both disorders, it's not always the case in Loeys-Dietz syndrome that the aortic root aneurysm has to be the first vascular event. And so that goes to the importance of the surveillance and keeping an eye on the whole vascular tree, so to speak, so that you can pick up the abdominal issue before, which might come ahead of the chest or vice versa. The other thing to consider here is that although arch surgery is, probably needed in both groups, aortic arch surgery is a totally different operation than just a root replacement. So root replacement, we worry about bleeding, we worry about the aortic valve, saving the valve, replacing the sinuses of Valsalva where the aneurysms form. But when you start going into the arch to do an aortic arch aneurysm repair, you then wind up taking on the risk of the vessels that come off the aortic arch, which all feed your brains and your arms. So the arch repairs are more technically demanding and they carry a different risk profile. So again, it does make sense that people try to avoid the arch unless the arch is directly involved by aneurysm or dissection.
Excellent, thanks. And so now we really get into your territory of type B dissections. And I think some people ask this question all the time of like, gosh, if you have a dissection, they think it automatically means you need to have an urgent surgery. And so kind of what are the things to consider with a type B dissection that help you kind of decide whether there needs to be surgery or not, kind of urgently?
Right, so I sort of made a vague reference to this earlier. If you just type in aortic dissection, you get the type A dissection, the immediate mortality risk, and that's obviously a very different conversation than type B dissections. Yeah. Type B dissections start at the left subclavian artery, so the artery feeding your left arm, running downstream, and for the most part, for patients with underlying connective tissue disorders, my sense in managing that group of patients versus those who don't have those disorders is that more often the patients with underlying connective tissue disorders more often have more extensive dissection, like the dissection just runs farther down, maybe even into the iliacs, which are in the pelvis, or even down to the femoral arteries all the way to the groin. So the dissections are trickier in connective tissue disorder patients, Marfan's, Loeys-Dietz, to a lesser degree, vascular Ehlers-Danlos. But the distinction about the type B dissection, they're all getting managed medically up front, trying to decrease the stress on the aorta. But there are some patients whose type B dissection rapidly progress or even can rupture. It's very uncommon. Totally, it's a single digit event for type B versus the type A's where it's a 50% in 24 hours. So, I think this is a situation where we watch the patients very closely. Pain, if the blood pressure cannot be controlled, then sometimes we have to pursue doing the surgery. Surgery to address type B dissection in patients with connective tissue disorders is a very, very difficult operation. So it's not something we try to get into very quickly. If we have to do it, we try and wait as long as possible for the tissues to essentially scar down or fibrose or get a little stronger. It's a much, much longer piece of aorta to manage throughout the entire chest than it is for the ascending aorta, which is only a few inches long. So it's a much, much bigger lift for surgery. But you see here, this is an important distinction, the uncomplicated versus complicated type B dissection. That is the first branch point. So everyone gets medical management. Everyone's the same with type B dissection. And then those who have complications from the dissection go down a route for more aggressive medical management or surgery. Those who don't have those complications stay with medical management as long as possible.
And what is medical management, or like how closely do you follow these things once someone has had like a non-surgical type B dissection?
So most of the patients will have a CT scan. We actually do a CT scan at discharge, and then one at about a month, then 3, then 6, and 12. And unfortunately, usually it's CT scans for the first 1 or 2 just to have really good info, and then we switch to MRI quickly thereafter. This is all about blood pressure control. So the data here is super clear about blood pressure. When you talk about blood pressure in the general population, the lower the better. You live longer, do better if your blood pressure is 130 versus 140. You also do better if your blood pressure is 120 versus 130. You also do better if your blood pressure is 110 versus 120. So most of our type B dissection patients, we try and keep their blood pressure under 120. And if they're doing fine at 120, then we even go lower. They come back in a month and they say, I feel good, and their blood pressure is 120, and we dial them up a little bit, try and go down even lower. So it's a little bit of, the analogy is kind of miles on the tires. You want to sort of decrease the miles on the tires if the aorta has been beaten up a little bit by a dissection.
And people may have come across this, but the difference between an open repair and then like an endovascular repair. So I know we have some pictures coming up too, but like what are kind of the differences or the pros and cons, or your opinion about this in connective tissue patients?
Well, so generally, this is a big issue. It comes up a lot, and the American Heart Association, of which I was one of the authors, is coming out with new guidelines on aortic diseases in November. But we've been holding the line, so to speak, to say that endovascular stent grafts really shouldn't have a place as primary therapy. So there is a, in an emergency, putting in a stent because the aorta is ruptured makes some sense, maybe in some complicated dissections, but for the most part, we know that patients with Loeys-Dietz syndrome, Marfan syndrome do very well with traditional types of surgeries, and the stents have sort of their own problem, so to speak. So we will eventually sort of bridge people if they do have stents to eventual surgery. And this is sort of a depiction of a slide that I've given at multiple talks of a person who had Marfan syndrome who went the route of stent grafting. So you can see a large aneurysm there. A stent is placed on panel B, and you can see at the bottom of panel B at the little white dot, and then a plume of blood sort of mushrooming up. That's a tear in the aortic wall from the actual metal inside the stent. That was managed with another stent, and then another tear happened in panel C, and the whole aorta essentially now is unraveled circumferentially on the inside. And then you can see instead of a double barrel aorta in panel A, we now have a triple barrel aorta that is manifest in panel D. And so this patient eventually underwent surgery to address this.
Yeah, so I think you touched upon this, but like the safe or like when to use it, I guess.
Right. So we will use thoracic endovascular pair when there is a strong reason to not try and do open surgery, such as a history of a pneumothorax where the chest was deliberately scarred to prevent pneumothorax, ruptures. Those things make sense. We also will use stents if we know there's an elephant trunk up top and there's a graft down below. So it's just bridging between two surgical polyester grafts. And then, of course, as you see here, the last reason is just get the stent in, get someone out of the weeds, and then get them somewhere where the next moves can happen most safely.
My next slide kind of transitions to like other arterial aneurysms and kind of your paper, but anything else that we haven't touched upon about the descending or any of those surgical interventions you want to say?
I think the key thing about really everything in the thoracic aorta is really about medical management. So I sort of alluded to sort of the importance of blood pressure control. And it is true that even despite really good blood pressure control, people with Marfan's and Loeys-Dietz can still get into type B dissections despite having maximal medical therapy. But in those scenarios where they're already on maximal medical therapy, it has not been my experience that they get into immediate complicated dissections. Yes, a dissection occurs, but they don't rupture, and they also don't get into malperfusion for the most part. I mean, I'm sure there are some out there, but it's not been my experience of managing patients with connective tissue disorders if they're already on maximal medical therapy.
Right. So we're kind of going to move on now to just are there arterial aneurysms, and this is actually from one of the Dr. Black's and his group's kind of original papers, just describing other locations of arterial aneurysms in Loeys-Dietz syndrome, with a high percentage being seen again in those carotid vertebrals, in the subclavian, starting to go off to the arms, and then in the lower abdominal aorta and branch vessels, including ones going to the gut, and then the iliac arteries going to the leg. And we'll kind of go through some other literature, I guess, too, that suggests that even though there might be some common places, we've pretty much seen aneurysms like all throughout the body and in many, many, many arteries. But so those were at least in our original kind of cohort where we saw the most prevalent other aneurysms.
Yeah, so this sort of goes to my comment earlier, like it's not actually that uncommon that the abdominal aneurysms precede some of the thoracic aneurysms. So again, the importance of surveillance.
And even though like this paper, I think was just our types 1 and 2, but there is evidence that like these multiple arterial aneurysms can present in other types of Loeys-Dietz syndrome, even though we're still learning a little bit more about that. So this is just some like pictures of different arterial anatomy in patients. So this is just a SMAD3 patient who had aneurysms of the celiac trunk, of the gastric artery. Oops, Angela, your dogs are going. And the common hepatic artery. So multiple arterial aneurysms in a SMAD3 patient. And then this is a patient that was kind of co-followed by Hopkins and down at Texas to an aggressive TGFBR2 variant or Loeys-Dietz type 2, where, you know, surgical intervention, if you do it prophylactically with an aneurysm, is actually quite successful and can be quite extensive. So this young man actually ended up having pretty much his whole aorta replaced, and then much of all the branch vessels going to his head and neck, and multiple arterial replacements, but for the most part did very well with all of those kind of grafts being sewn together. I was so grateful for Dr. Black for sending me this slide one day, because we get questions all the time and I'm always like splenic artery, iliac artery. So this came out from, I guess, the Journal of Vascular Surgery. And I guess my question, Dr. Black, is like, routinely for those arterial aneurysms, like you just, I'm gonna quiet her, there we go. Do you use generalized management, or does like the rules change for Loeys-Dietz syndrome?
You know, generally speaking, all of the visceral aneurysms are pretty rare, and there's a number of visceral aneurysms where the repairs themselves are pretty hazardous in general, particularly, for example, the superior mesenteric artery, the one that feeds 90% of your intestinal surface. So, so we're pretty cautious with a lot of these types of interventions, and I'm pretty hesitant to drop the threshold substantially on all of these aneurysms from the numbers you see here. The splenic artery aneurysms, I do sort of drop down to 2.5 centimeters, but the other ones, for the most part, will stay pretty much in that sort of range, just because the downside of the downside risk of the procedure is not insignificant.
My next slide transitions to neurovascular stuff. Just any other like tips and tricks or other comments you want to make about any of those visceral artery aneurysms or other arterial aneurysms?
Sure. I mean, I think one of the things although we're not really speaking directly to it this evening, but vascular Ehlers-Danlos syndrome, you know, the prevalence of splenic artery aneurysms, renal artery aneurysms, iliac artery aneurysms is definitely bigger and can be more severe. The good news is that with catheter-based interventions, so this is what we call the endovascular surgery. So going up through the groin, working through the vessels directly, and then dropping into the celiac vessel to get to the splenic, or dropping from the aorta into the renal artery to get to the renal aneurysm. You know, we are now able to handle a lot of these types of aneurysms you see here on the picture without opening up someone's belly or, you know, doing traditional types of surgery. You know, it's for the most part catheter-based interventions where we very carefully work our way through the vessels to clot or block or stent these aneurysms off.
And do you see any of the, or have any of the same concerns with, like, when you hear stent, now we get worried about the other stents you talk to, but like stenting of the iliacs or any of these, like, do you get concerned about that at all?
It's less of an issue in these areas, mostly because the surgical salvages are much easier to handle versus sort of up in the chest where there's just a lot of blood flow going through those vessels at any given time. For the majority of the aneurysms you see here, we actually just coil them off with metal coils. So the purpose of the coils is to agitate the blood flow inside the aneurysm to the point where it actually starts to stagnate. And then once it stagnates, it clots. And of course, a clotted aneurysm is a much less likely aneurysm to rupture.
Great, thanks. You know, so we briefly wanted to touch upon neurovascular findings or aneurysms. And so really, you know, a word about intracranial aneurysms is that they usually are asymptomatic and usually just found incidentally on pickup of imaging. And I always get scared to hear this, but in general, they're pretty common in just the general population. About 2 to 3% can have a brain aneurysm, but clearly what we get worried about is a rupture of this aneurysm that can cause a bleeding and a stroke. So in general, there are risk factors for brain aneurysms. So clearly things that we tend to want patients to avoid in terms of high blood pressure, drug use, cocaine use, cigarette smoking, heavy alcohol. But also we know that clearly aneurysms, brain aneurysms are highly associated with connective tissue disorders, polycystic kidney disease. And also just a point of this of like the family history of brain aneurysm. So we can also see this in Loeys-Dietz families. Like if you have 2 or 3 individuals with brain aneurysms in a Loeys-Dietz mutation positive family, we might, image you more frequently, or we might make some different recommendations based on that family history, because we can see sometimes that cluster in a family. And so just like we talked about earlier, there can be different types of aneurysm. There can be a saccular aneurysm versus a fusiform aneurysm. And where this gets a little bit tricky just with like the MRA imaging we do that can be a little bit fuzzier is that, sometimes people might have had this on their own reports where it's a little unclear whether it's an aneurysm or something called an infundibulum. And so you can see here, like the aneurysm on the kind of left side of that panel on the right, where it really is this outpouching that is separate from where the artery naturally branches out. Whereas my understanding is that an infundibulum is kind of just a widening of that neck, which can actually be a normal variant. So a lot of times on MRAs or even CTAs, we'll get this like question of what is it and how does tortuosity impact it? And in that case, sometimes we do like CTAs if you've had an MRA, but we always weigh the pros and cons with our neurovascular colleague with kind of going in and doing more invasive kind of catheter fluoroscopic techniques to actually get clearer pictures of the blood vessels. It kind of removes the bone imaging and gives you clearer pictures. So again, the theoretical fear is if you're doing a catheter up a windy blood vessel, could you cause an aneurysm, or if it's tortuosity, like, is it more dangerous? I would say we don't have to do this infrequently, but the patients who've had it, we haven't had complications. And then, the symptoms really of a ruptured aneurysm, the worst headache that you've ever had in your life, nausea, vomiting, seizures, light sensitivity, but usually these are very asymptomatic. If they get large, they might press on other tissue and cause issues, but usually, again, they're kind of incidental findings that we see. So people always say like, oh, I have headaches. I'm really worried about a brain aneurysm, but headaches are usually super common in connective tissue disorders, and we don't normally see them as the cause of a brain aneurysm. And I think these are techniques also for the visceral blood vessels, or at least some of them. But when we think about repair, I know that I've seen case reports in literature that describes at least A, B, and C in Loeys-Dietz syndrome, and I haven't just seen anything about the pipeline embolization. But to take care of these aneurysms, you can see surgical clipping. So really putting a clip in, especially if it's kind of a smaller neck aneurysm, like Dr. Black described, kind of coil embolization, getting coil in there and clotting it off. And then I have at least had a patient who's had kind of wrapping of an aneurysm where you kind of wrap it in the kind of material and felt to help it from growing and if from not rupturing. There was an interesting paper that came out. So if anyone is having problems getting insurance coverage for vascular imaging of the head and the neck, this is the group from Texas that reported on pediatric patients. And it's a little bit hard to interpret, but out of their cohort of, I think about 47, I think there was actually 39 patients who actually had the neurovascular imaging. And their rate of having a cerebral aneurysm was about 8%. So in their article, they propose that, clearly everyone should get it at baseline. And then depending upon if there's tortuosity or not, like how frequently you should get it. I do disagree. They said that if it's normal, that you can wait 5 years. I think we're still a little bit uncomfortable with that. We don't see that aneurysms grow super fast, but maybe not 5 years. We'd still kind of recommend that 2-year time frame for looking at head and neck vessels. So I had the opportunity to try to take some time this spring and kind of go through the literature and actually pull kind of larger cohort papers and like, what is the percentage of head and neck aneurysms that we see, or arterial aneurysms? So I will say, the truth is usually somewhere in the middle. I've broken it down by gene, but a lot of it depends upon who is doing the reporting, whether it's like a neurosurgical place or a vascular place, or people who are really on top of making sure that all the patients get vascular imaging. So you know, in general, you can see that types 1 and 2 and even 3 for Loeys-Dietz syndrome, kind of the cerebral aneurysm mix is kind of somewhere probably around 20% in terms of cerebral aneurysms, and the total arterial aneurysms may be up to like 20 to 40%. So all of this is just really data to suggest why vascular imaging is important, because aneurysms, arterial aneurysms, are presenting in about 1/4 to 1/3 of patients. You know, there's just at least less data in kind of types 4, 5, and 6, just because we haven't known about you as long, and so we have less vascular imaging. But still, at least in our cohort data at Hopkins and kind of what's been reported, the total arterial aneurysm and dissection rate is still around like 10 to 20%. SMAD2 as well, kind of around that percentage. So really, you know, this just makes the case for getting the vascular imaging. And I was thinking about this next slide. I went through our own cohort and then like big cohorts that I could find and kind of went through the vasculature and kind of X'd off what has been reported. And I'm probably need to put a poll up like on Facebook or the Loeys-Dietz Syndrome Foundation, because I bet we could X off a whole bunch more arteries if I actually just asked people. But clearly you can see, at least in the head and the neck vessels, that types 1, 2 are kind of grouped together, and type 3 are the most common reported aneurysms in the head and neck, but all types have in the literature been reported with some type of cerebral aneurysm. And then 2, this is kind of looking at the rest of the body. So even though clearly types 1, 2, and 3 are more aggressive in terms of arterial aneurysm, there's still kind of a wide distribution of arterial aneurysms seen in the other types. So I was happy to get to go through this finally and educate myself as well. So this is kind of the end of like the formal presentation, unless Dr. Black that you have anything, but we're happy to take any questions or things like that through the chat.
Yeah, I think, you know, this picture sort of just reflects the fact that, you know, we have a great number of locations where people can have aneurysms, but they're all effectively picked up on pretty standard imaging, which is sort of nice. So I think the ones that might be a little more rare, for example, the ones way out on the hands, way down on the legs, a lot of those we can detect just on physical exam. So, you know, I think everyone should feel assured that, you know, if some of these things develop, we have really good treatment strategies and a good understanding of the syndromes to sort of help guide the treatment overall.
Yeah, I remember you teaching me that once with our cohort of brothers who had the popliteal aneurysms, and I was like, oh my gosh, do we need to be like going lower? And you said that usually it's palpatable, so not a problem. You can usually tell when those are occurring.
Yeah.
And would you just, I guess, say like, talk about, you know, your experience with the tissue? I know like the differences between Loeys-Dietz and vascular EDS, but in general, I think people do pretty good with all the other interventions. Would you agree?
Yeah, I generally agree. Yeah, I mean, I think particularly if you're talking about aortic diseases across the board, all the different genetic syndromes have a good performance with surgery. Even vascular Ehlers-Danlos syndrome, because the VDS patients who tend to get aneurysm or dissection disease in the aortic segment tend to actually have a slightly different genetic substitution that does allow some collagen to be secreted from the cells. So, you know, for the most part, we've been able to handle all these well. It's noticeable though. I mean, it's a little bit different than operating on someone who doesn't have an underlying syndromic disorder, but we have techniques at the time of surgery that help us sort of get through that overall.
And I will just say something, because I was like, there's no questions, but Dr. Black has been the one answering the questions. He comes up as Gretchen because he has my login, but rest assured, all the questions are being answered by Dr. Black. So
yeah, that'd be impressive if you were talking and answering. No, I've been.
I know. I was like, why are there any questions that they come up in a different section? So, is there anything from the questions that you wanted to address, or does any? I guess Angela, do you have anything else that's come up?
No, they've been everything's been answered very quickly. So I would say if anyone has other questions or wants a clarification on anything from the presentation, now would be the time to drop those either into the Q&A or
Like
chat.
I said, I've been answering as we go, but I think, you know, the last question from Rachel Murphy was about if you have an aneurysm in one location, what does it mean for the aneurysms in the other location? And I answered that to say that these are mostly independent discussions. You know, the hemodynamics, the forces on different blood vessels in different locations is actually quite a bit different. So I would still answer that, you know, just because someone had a terrible thing happen in one segment doesn't necessarily mean a terrible thing is going to happen in another segment. But I did sort of buttress my answer or bookend my answer to say that if there's a strong family history of aortic rupture, aortic dissection, that sometimes can make us lower the surgical thresholds, you know, to handle what would seem to be at least, you know, a more tough or malignant profile in some patients and some family pedigrees. So that's where it really gets to be super important to sort of have a really strong, you know, genetics team who understands your disorder really well. And of course, you know, I benefit from having the pro of all pros between Gretchen and Hal here at Hopkins. So, but for those of you who are not close to Baltimore, who obviously need to work closely with your genetics team to sort of have some of those conversations and make sure that all the different things have been flushed out in your family history.
And also I'll just say, like, again, I was super excited to kind of put the slides together for this talk because people have variable knowledge bases, but we'd also love to get feedback, like let Angela know or let us know in the chat about like other questions that you have regarding this topic. And if we're missing big things that you really have questions about, but we really thank you for this opportunity to kind of take a step back and think big picture.
And there was one more question just about myosin mutations. It's something we didn't really talk about here tonight. The myosin and actin mutations can actually look a little bit like Loeys-Dietz syndrome. The question is about diagnosing someone with Loeys-Dietz if they have a myosin mutation. That's probably not totally equivalent. But patients with myosin mutations sort of generally fall into the surveillance category and the need for blood pressure control that we talked about among all of the disorders for all of the reasons I mentioned about better survival and better health over decades.
Yeah, and Chris, I guess if you have questions about genetics or variants or things like that, I'll just drop my email in the chat. And if there's ever genetics questions, just like send me copies of your reports and we can kind of look at that and figure that out for you.
I'm not seeing any other things come up. So I think with that, we can say thank you so much to the both of you. What a good balance of presentation between like getting into the details and really like maybe going a step further than what a person could learn on their own, but also keeping it rooted in some of these basics that I think any people at all levels of trying to learn this information could get something from this. So truly thank you both for your time, for putting this whole thing together and allowing us to offer this to our community as we wrap up Loeys-Dietz Awareness Month this year. So thank you both. Thank you, Gretchen, for dropping your contact information in the chat. As always, you can get a hold of me at loeysdietz.org, and any other questions that you think of in the middle of the night that you wish you had asked on this webinar, do take them to loeysdietz.org/ask, and we'll make sure that you get that information just as quickly as possible. So with that, I will say goodbye and thanks again to Gretchen and Dr. Black.
Thank you, everyone.
Everyone.
Bye.
Bye.